To start, I'm going to do a quick overview of visual perception since we'll be going into more detail on this topic in class. Vision is viewed as a dominant sense to help people understand the world around them. So when there's a deficit in visual perception, all areas of occupation are impacted. Visual perception is one of the least understood areas of evaluation and treatment. Visual perception involves sensory and cognitive functions which help understand the visual stimuli in our environment. And visual perceptual skills include the following, but they're not limited to recognizing and identifying shapes, colors, and objects, including the size of objects, the configuration, and the spatial relationships of objects to one another. And in the OTPF, visual perception is included under client factors, specific mental functions. Here's a picture of the hierarchy of visual perceptual skill development in the central nervous system. This picture is from a research article by Mary Warren, 1993, and although it's an older article, it's still relevant today. In the article, she talks all about the hierarchy of visual perception and how it's similar to many other developmental models, as it involves many visual skill levels that build on top of one another. And you need visual scanning to be efficient prior to gaining pattern recognition. Without the foundation and support of the lower levels, one won't be able to acquire higher level skills needed for visual perception. So when an injury, for example, an acquired brain injury takes place, all of the skill levels are vulnerable to injury. So if someone has a stroke that impacts their attention or scanning abilities, all of the visual skills that are above those skills will be damaged as well. Warren has expressed that evaluation and treatment for visual perceptual skills in someone who has undergone an acquired brain injury or stroke should be focused on the lowest level affected and identify where the injury has happened in the brain in the hierarchy and how that skill can be restored and remediated. In terms of visual perception impairment, there are many diagnoses that have visual perception impairments that result in decreased function, including traumatic brain injury, stroke, low vision diagnoses, CP, developmental and intellectual disabilities, including Down syndrome and dyslexia.
Evidence for visual perceptual training, or VPT, has shown that it can be used for many different diagnoses that can either be congenital, developmental, or acquired. VPT can be provided to clients in the traditional method of paper and pencil or computer-based software. The basis of VPT is that each component skill of visual perception is specifically targeted. Examples of this would be for visual attention, something like puzzle solving, or for visual closure, completing simple shapes. Whether the training is aided with paper or computer, generally the task is identical. More examples can be seen in the chart. There is no specific guidelines for how long or how often intervention of this kind should be implemented, which results in each study using their own guidelines for duration and frequency of intervention. Visual perceptual training practices these skills through sensory experiences and among different contexts to enhance carryover. One study used VPT with children with cerebral palsy, and they investigated ADL functional outcomes. This program was 24 sessions for 30 minutes over the course of 8 weeks. They found that VPT showed an increase in performance for self-care, mobility, communication, and social cognition, according to an independence measure. Another study used this intervention with children with dyslexia. This intervention was for 10 weeks for 30 minutes every 2 weeks. A home program was provided and expected to be completed daily and logged. These children showed improvements in specific visual skills of discrimination, form constancy, and figure ground. Of all diagnoses and studies we read, this study had the least promising outcomes. Computerized VPT targets the component visual skills through software. In a study specific to children and young adults with Down syndrome, intervention length of 1 year was based on the premise of mass practice and repetition. For this intervention, it included Microsoft Paint software, puzzle software, and memory software. Following the intervention, participants improved on all the subtests of the test of visual perceptual skills. Michaela Cardone will be presenting on this assessment this week. Depending on your personal order of asynchronous learning, you might not know what the subtests are. So they are visual discrimination, visual memory, spatial relationship, visual form constancy, visual sequential memory, visual ground, visual figure ground, and visual closure. This study also found that VPT resulted in more brain activation shown by an fMRI. The areas that had more activation were involved in spatial manipulation and motor imagery. Computerized VPT was also used with children with low vision. These children, post-intervention, saw changes in their social participation and occupational engagement measured by specific assessments. Overall, VPT in either form was shown to be effective for multiple diagnoses in either improving the perceptual component skill or in function, depending on the specific study.
The majority of people who are diagnosed with an acquired brain injury, including TBI and stroke, have visual perceptual deficits as a secondary impairment to their injury. According to a Level 4 descriptive study and a Level 1 systematic review, the primary approaches to treatment are remediate, educate, and compensate. According to Warren, 1993, remedial and compensatory combined is the best intervention strategy. Client education is important because it helps them increase their awareness of their deficit. Overall, visual scanning techniques and trainings, including visual anchoring techniques, are beneficial for increasing one's visual perception, especially for individuals with left neglect, as it broadens their visual field, allowing them to perceive and take in more information from the environment that they may have not been perceiving prior to the training. According to Mary Warren, other treatments include reinforcing the visual experience with a sensory motor experience, remaining attentive or consciously paying attention to detail, including colors, shapes, and sizes of objects in the impaired space, and practicing a skill with multiple contexts. This ensures carryover, which is difficult for patients with brain injuries. And according to the systematic review, other interventions include adaptive strategies, which include prisms and scrolling text, an assortment of vision therapy, and cognitive interventions, which include cognitive retraining strategies. In terms of vision therapy, I'm not going to go into too much detail, as an eye care specialist is typically one who performs these therapies rather than an occupational therapist, but it's important to note that audiovisual stimulation is more effective for improving reading performance than visual restorative therapies, and there's strong evidence that people who participate in cognitive retraining strategies improve their visual perception overall.
Table tennis training is a specific intervention protocol that we found to be interesting, and this study was done with children with mild intellectual disabilities. Training involves warm-ups, specific table tennis performance skills like serving, playing with a coach, and then a cool-down. This study found that it was more effective than standard OT for visual perception and executive functions, according to assessments. One thing I found interesting was that the attendance rate of table tennis training versus standard OT was better. This made me think of motivation and the motor learning factors we discussed in neuro. For some kids, this may be a way to find their inner drive.
Application for clinicians. Occupational therapists should recognize and understand that many diagnoses we treat will have some form of visual perceptual deficits, and vision should be one of the first things that we assess before treatment. Clinicians and therapists should consider the following approaches when working with someone who has a visual perceptual deficit: establish, restore, compensate or adapt, and educate, as these approaches are the ones that Alexis and I found most throughout the research. Lastly, many visual perceptual training techniques focus on component visual perceptual skills, but as occupational therapists, in order to remain holistic, we should strive to use these trainings in conjunction with function-based activities.
As Kayla and I were researching this topic, we found it difficult due to the lack of evidence and very little commonality between the studies. There is a need for more studies, and these studies need to be more rigorous. There is also minimal systematic reviews available due to the limited evidence. Following more studies being completed, systematic review should follow. These future studies should focus on long-term effects on function. For example, the table tennis article was only a 16-week comparison of pre to post scores on the visual perceptual test. It would have been useful to know if these improvements lasted and if they had functional implications.